Hello, let's talk about chronic myeloid leukemia and other myeloproliferative diseases. I want to start by defining a myeloproliferative disease. Any myeloproliferative disease is technically a neoplasm, so it's a clonal proliferation of cells. Where is it? It's in the bone marrow. That's what myelo means. So it's a stem cell disease and it's neoplastic, therefore it's lost all regulation and nothing can inhibit these stem cells. So they divide and multiply out of control and they end up in the peripheral blood. So that's how we diagnose myeloproliferative neoplasms, is by observing in a blood smear or a CBC a gross excess of red cells or of platelets or of white cells, because that indicates to you there's a stem cell in the myeloid lineage that's multiplying way too rapidly, way too much. So myeloproliferative neoplasms take a long time to really develop. These are diseases of the elderly. The 6th, 7th, 8th decade of life is when you most commonly see these 4 diseases, and there are 4 main myeloproliferative disorders. They're CML, which is a white cell disorder, polycythemia vera, which means you have too many red cells. Then there's essential thrombocythemia, which is a platelet problem, a megakaryocyte problem. And then there's primary myelofibrosis, which is also a platelet problem. So you can understand then that any of the 3 cell lineages in the bloodstream can be affected by a myeloid stem cell disease, because your myeloid lineage, that's basically everything that's not a lymphocyte. So red cells, white granulocytes, and megakaryocytes, those are your 3 cell lines. They all can develop a cancer, okay? And so then the different cancers are just which cell line is affected. Now let's talk about chronic myeloid leukemia. There's a case here in this SDL, but I'd rather look at some practice questions. A 48-year-old woman shows up because of left upper quadrant pain and chronic fatigue. Now she's got an elevated white count, 95% of which are neutrophils. She's also got a little bit of a basophilia. Normally that should not be above 1%, but it's 2 here. And then you notice she also has elevated red cells and platelets. So she has cytoses across the board, and you know it's a myeloid problem because granulocytes, red cells, and platelets, all 3 cell lineages of the myeloid family, are affected. So, of course, you take a blood smear, and then you probably get a bone marrow very soon afterwards. You look at the bone marrow, and there is an extreme overproduction of white cells within the bone marrow. And these are going to be granulocytes. You can see granules in them. Some of them have those monocytic kidney bead nuclei. You see some neutrophils. So you understand this is a myeloid disorder. And then the question is, well, the patient's treated with a drug that inhibits the oncogene product in this disease. So this would force you to make the differential between a CML and an AML. And then the answer to CML is defined by the Philadelphia chromosome, which is a fusion product, BCR-ABL, and it's going to produce an overactive tyrosine kinase. So you need to know that imatinib is a tyrosine kinase inhibitor that is frontline for almost every CML. I would say every CML because, again, CML is defined by the Philadelphia chromosome. Another question, typical case, 57-year-old asymptomatic man shows up for a routine examination. You look at a blood smear and there's extreme neutrophilia, very high white count, myelocytes are high, metamyelocytes, those are high, eosinophils and basophils are elevated. So virtually every cell of the myeloid white lineage is up. And then you look at this test called leukocyte alkaline phosphatase activity, and it is low. So this is pretty important here. Sometimes you have a lot of neutrophils in the blood because you have sepsis or any other bacterial infection. Sometimes you could have what's called a leukemoid reaction to that bacterial infection, and then your neutrophils are going to be in the 30, 40, 50, 80, 90,000s, right? So the way that you tell that sort of appropriate immune response apart from a cancer is to do a leukocyte alk phos test, and that's LAP, and you might see it called neutrophil out phos, or NAP. So how we do this test is we basically do flow cytometry, and we're looking for the presence of the LAP enzyme inside neutrophils. Now, LAP is present inside normal neutrophils, but if there's a myeloid cancer, a cancerous neutrophil does not express leukocyte alkaline phosphatase. So we send these cells through a little column with flow cytometry, and we count. And we say, oh, okay, you've got LAP, check, +1. The next cell, that's got LAP, 2. Okay, the next cell has LAP, that's another one, 3 total. So you get a 1 if you have an LAP and a 0 if you don't. Then you add them all up at the end. And normally you've got a nice big number because normal neutrophils have LAP. But in a white cell cancer like CML, that score is just about 0 because those neutrophils do not express leukocyte out phos. And so you're just counting the LAP expression in this flow cytometry, and it's like 0, 0, 0, 0, 0, 0. So that's LAP. That's a very important test for distinguishing a leukemia apart from a normal, or physiologic rather, neutrophilia. So in this particular question, they ask, what's the appropriate treatment for this patient's condition? We go back and look, and myelocytes, neutrophils, this patient doesn't have lymphoid anything, lymphoblastic nothing. It's clearly a myeloid problem. So then, is it acute or chronic? And to answer that, you can look at the blast percentage in the peripheral blood or in the bone marrow, either or. And if that blast percentage is less than about 20 or 25, then it is a chronic myeloid leukemia. It is not acute. Acute myelogenous leukemia is defined by very, very elevated blast percentage in the blood or the bone marrow. So they ask you the treatment, and again, that's imatinib. There's that all-trans retinoic acid to throw you off. Remember, that's a treatment for acute promyelocytic leukemia, which likes to present with that 15-17 translocation in DIC. And then a few other chemotherapeutics there. None of them are the right answer. Imatinib, that's that kinase inhibitor that we're going to throw on anything with a Philadelphia chromosome. A couple of smear photos of CML right here at the beginning will help you understand what's going on. A lot of white cells in the blood. That's it. They're all of the myeloid lineage. You can tell that they've got kind of characteristic kidney bean nuclei, a lot of them. This one down here, lower left, that's a monocyte. And a lot of neutrophils, with multilobular nuclei, maybe 2 or 3 or 4 lobes is normal for a neutrophil. So many monocytes, many neutrophils, elevated white count. You're thinking CML. You take a leukocyte alkaline phosphatase score, and if it's 0, then you're dealing with a cancer. If it's normal, then you're dealing with a physiologic reaction to an infectious process. And then what else are you going to look for to diagnose CML? The Philadelphia chromosome, because every CML has a Philadelphia chromosome. Well, let me rephrase that. Every CML has a 922 translocation, and out of those, 95% of them are the standard Philadelphia chromosome. Another CML here, elevated myeloid precursors in the blood. See that kidney bean nucleus. Can't really see granules in many of them, but you do pick up neutrophils with many lobes. So a neutrophilia. Same thing here. Neutrophil, those are normal. These are big old cells here. Use yellow for them. Wow, those are a lot bigger than the surrounding neutrophils and red cells. So we would call those myeloblasts, or maybe promyelocytes, metamyelocytes, anything really of the myeloid lineage. In CML, the whole myeloid lineage tends to be involved. You look at the bone marrow, it's going to be hypercellular. And here's an important concept. In chronic myeloid leukemia, there's phases to it. So kind of like how you were a little kid and then you hit puberty and you were a teenager and then you walked out on the other side of that tunnel and now you're an adult, or at least society calls you one, So just like that, CML has phases or stages. You have a chronic phase, which the bone marrow is hypercellular, but patients typically don't have very many symptoms. Then you have an accelerated phase in which the bone marrow visually starts to go downhill and patients begin to come down with B symptoms maybe, or start to develop organomegalies due to extramedullary hematopoiesis as the bone marrow gets more and more eroded. And then you're going to end up in what's called a blastic phase. And that blast phase means that essentially the patient's CML has transformed into AML. There's going to be an elevated blast count. And at that point, there's not much that we can do therapeutically. So to the SDL, myeloproliferative diseases is essentially a cytosis of one of the three different cell types in the peripheral blood. You could have elevated white cells, that would be a CML. You could have elevated red cells, that would be a polycythemia vera. You could have elevated platelets, that's an essential thrombocythemia. And then there's this one called primary myelofibrosis, which is also a platelet neoplasm, but because platelets make things like transforming growth factor beta, there's a big fibrotic response in the bone marrow sometimes. Now, what defines myeloproliferative disorders clinically? Number one, they're very, very long diseases. They take decades to develop. You really don't see them in people in their 20s and 30s. Number two, you have elevated cell counts of a particular lineage or maybe multiple lineages, and that's what sets a myeloproliferative disease apart from a myelodysplastic syndrome, because they both involve the bone marrow. And they're both technically neoplasms of the bone marrow. But in a myelodysplastic syndrome, there's something really, really wrong with the clonal cell, and it dies before it can even get into the peripheral blood. So in MDS, myelodysplastic, you see cytopenias, versus in a myeloproliferative disease, you see cytoses, because there's nothing wrong with the cells. They're going freely out into the peripheral blood. Talking about phases of CML, again, pretty important to understand. Patients may present totally asymptomatically, maybe just have a slight organomegaly. So this is a differential you want in the back of your mind, something you want to keep in your pocket whenever you do see something like a hepatosplenomegaly in an elderly person with no otherwise obvious symptoms. And then it accelerates and then it blasts off, which is, again, a transformation into an acute leukemia. And we define these phases by the blast count. 10 to 19% is going to be accelerated and over 20% is going to be blastic. Let's talk about CML specifically. Right off the bat, please understand every single chronic myeloid leukemia case has a BCR-ABL fusion gene product, and usually the vast majority of the time that's due to a typical 922 translocation that we call the Philadelphia chromosome. And we have lots of different tyrosine kinase inhibitors. That's important for you to know, because this BCR-ABL fusion gene is a constitutively active tyrosine kinase, which means it will not turn off. It is always on. Up to half of patients with CML are asymptomatic at diagnosis. I like this part: uncommon presenting symptoms, tenderness over the lower sternum. So you might go working up an AMI or something, or coronary syndrome, but really it's not even musculoskeletal. It's literally bone pain, because there's such a degree of clonal proliferation occurring in the bone marrow. And please remember that, especially as you get older, the primary hematopoietic sites in terms of bone are going to be your skull and your sternum and your ribs, the axial skeleton. So the sternum and the skull are where you would see bone pain first. Also, patients might present with a gouty arthritis, and gout, that's a purine excretion problem. And so you could be overproducing or underproducing or under excreting purines, right? And a purine is going to be any nucleoside with adenine or guanine, right? And so those get degraded down by this enzyme xanthine oxidase, correct? And then we've got drugs that block xanthine oxidase, such as allopurinol, which would be a great choice to give a patient presenting with gouty arthritis secondary to a neoplasia. There's also things like febuxostat, pegloticase, a lot of different drugs that can deal with that gout problem. Hyperviscosity syndrome, well, you're hypercellular in your marrow, so you're very often hypercellular in your blood too. And palpable organomegaly, again, very, very common symptom. In CML, white count's always elevated at the time of diagnosis. Those will be myeloid cells, not lymphoid cells. Hyperuricemia is an indicator, again, of cell turnover. And remember that uric acid can crystallize inside the kidney or the renal pelvis or the urethra and end up popping out a stone. And so that could also be an initial presentation of somebody with a CML. You take a peripheral smear, you see granulocytes at all stages of differentiation. I think this is pretty important because, you know, unlike ALL, in which you see lymphoblasts, period, unlike maybe CML or CLL, where you see normal lymphocytes, there is not one particular cell that's indicative of CML. Instead, you see a whole bunch of just about every myeloid white cell in the blood. Paragraph at the top of page 4 talking about how to tell apart a standard leukemoid reaction from a myeloid leukemia. So you could read all that about cell counts, or you could just understand that leukocyte alkaline phosphatase or neutrophil outphos is going to be elevated in a leukemoid reaction and decreased. It's going to be almost flat zero in a myeloid leukemia because leukemic cells do not express that neutrophil alkaline phosphatase. The absolute basophil count is always increased in chronic myelogenous leukemia. The megakaryocyte compartment is typically increased, more so fascination than really an important diagnostic marker, but you do tend to see small megakaryocytes in CML as opposed to larger megakaryocytes in maybe myelofibrosis or essential thrombocythemia. You could see some Gaucher cells. That's not super important. I'm sure that you understand Gaucher's disease is characterized by tissue paper macrophages. That's the buzzword. And so if you see tissue paper cells in the bone marrow, CML could be on the differential. CML typically stains myeloperoxidase positive. As a reminder, MPO is present in myeloid and monocytic cells, but not in cells of the lymphoid family. Therefore, MPO is an important marker for discriminating a myeloid leukemia from a lymphoid leukemia. Genetics. Every case of CML expresses a 922 translocation with a BCR-ABL fusion product. 90 to 95% of the time, we're going to call that the Philadelphia chromosome, which is acquired and is not inherited. So patients very often ask, oh my gosh, is my child going to get this, or my children, because I have this leukemia? And the answer is no, this is acquired. And the other 5 to 10% of the time, there's a quote unquote cryptic variant of this translocation that is very tough to identify. And we would call that Philadelphia chromosome negative, even though the same BCR-ABL fusion product is still present. So the chimeric gene is again constitutively activated. It's a tyrosine kinase. You can't turn it off. You get persistent growth pathway signaling leading to uncontrolled proliferation. That's the carcinogenesis of CML. At the bottom of page 7, top of page 8, referring to the progression or phases of CML. Understand we're telling them apart based on the percentage blasts in the peripheral blood and in the bone marrow. Less than 10, we call that chronic phase. 10 to 20%, we call that the accelerated phase of the disease, in which symptoms typically start getting a bit worse. And then in the blastic phase, with greater than 20% blasts in marrow or blood smear. And also one more criteria for the blastic phase is extramedullary localization of the cancer. If you meet those two criteria, it's about to get pretty bad. Now, when you transform from a CML into an acute leukemia, you can actually de-differentiate to the point where you start seeing lymphoid markers on these blasts. And so lymphoid markers include TDT, terminal deoxynucleotide transferase, which is typically on pre-lymphocytes. And then there is also the expression of pre-B, CD19, CD20, maybe a CD5, sometimes after this CML transforms into an acute leukemia. CD33, CD13, I want to say 103, 1-something-3. Those are going to be your myeloid markers. And when it comes to treating CML, we have three main options: the bone marrow transplant, the allogeneic HCST, HSCT. So allogeneic means it's coming from, for example, your brother or your father or your mother. Somebody with a very similar HLA type to you, almost identical, is going to be giving you some stem cells to put into your bone marrow. We're going to go in and completely wipe out your bone marrow, get your stem cell count down to like practically nada, zero. We want there to be 0 cells in your bone marrow. We want them to be empty. So basically, we're going to take this cup and dump all the water out of it and put some different water back into it. That's it, HSCT, yes. So that's different from autogeneic, right? Which would be we're taking your own cells out and then we're frying your bone marrow and then putting your own cells back in. So allogeneic, definitely higher risk for transfusion reactions on down the line compared to autogeneic. Then the second therapeutic pillar for CML is the tyrosine kinase inhibitor imatinib. Imatinib, you want to recognize that word for sure. They expect second-year medical students to understand that's going to be our treatment of choice for just about any CML. We're going to be throwing imatinib at it to see if it works. That's our first-generation tyrosine kinase inhibitor. If that one doesn't work, there are some newer drugs, second and third gen tyrosine kinase inhibitors that we could try out and see if they would work on a particular patient. And then finally, once we get to the blastic phase, then we've been using the tyrosine kinase inhibitors. They didn't stop the patient from reaching the blastic phase of their CML. So we're going to shift into palliative care mode at that point. And there's really not a lot of practicality in continuing a tyrosine kinase inhibitor at that point. So that's CML. Let's talk about essential thrombocytosis. I believe this paragraph, if you understand what's going on in this paragraph, you're going to get the whole disease. You barely have to practice it. Essential thrombocytosis is characterized by sustained thrombocytosis with platelet counts in excess of 450K, bone marrow megakaryocyte hyperplasia, leukocytosis, splenomegaly, and a clinical course punctuated by bleeding episodes or clotting episodes. So essential thrombocytosis is a megakaryocyte neoplasm. The megakaryocytes, one gets a mutation, becomes clonal. You get a bunch of megakaryocytes in the bone marrow. They're all making platelets. Your platelet count in the peripheral blood is 500,000, 800,000. So as a result, you get clots very, very frequently in some pretty bad places. And to diagnose it, you look at absolute platelet count. You might also want to look at the bone marrow. But that's about all that you have to know about this disease. If you do take a blood smear, here's an example in the lower right corner of page 10, in which there's massive aggregations of platelets inside the blood smear. And on the lower left, here's a bone marrow with like 5, 6, 7 megakaryocytes all huddled together very closely. So that's an abnormal number of megakaryocytes. In terms of symptoms, pregnancy loss, common presentation, splenomegaly due to the sequestration of all of those platelets in the blood. Something interesting, hemorrhagic events, because apparently once you get above 1 million platelets in your blood, then you actually start using so much von Willebrand factor that you get deficient in it. And so this is very similar to DIC, in which you're clotting in so much that you're using up all your clotting factors, so you end up with a deficiency. Same concept here. For a platelet to stick to exposed endothelium, it needs some von Willebrand factor binding collagen on one side and GP1B on the other. So the more platelets you have, the more von Willebrand factor you're using up. You're eventually going to get acquired von Willebrand syndrome. I thought that was pretty cool. But you understand the histology, you're going to be bulletproof for these questions. There's no way they could throw this one by you. It is a 80-mile-an-hour fastball. It is easy to hit. Pathology, giant megakaryocytes, clusters, hyperplasia. What's the mutation? Usually Janus kinase 2, which gives you a constitutively active erythropoietin receptor. And sometimes, more rarely, there's a calreticulin mutation, which is involved in calcium homeostasis, but usually the mutation, the driver mutation for this neoplasm is going to be that JAK, Janus-associated kinase 2. Now, treatment for a patient with essential thrombocythemia, you for sure want to give them aspirin, which is going to inhibit thromboxane, which is a potent vasoconstrictor and thus mediator of platelet aggregation. Remember that if you're a platelet and your job in life is to just stick to the wall, right? Then if there's more blood flow going through an artery, if it's dilated, it's going to be tougher for you to perform your job compared to if that artery was basically clamped down and shut, allowing for slower blood flow and making it easier for you to just grab onto that wall. So that's how aspirin works. Irreversibly inhibits thromboxane A2. And so remember, a platelet's got a shelf life of 2 to 8 days. So if a platelet gets hit with some aspirin, that means that for the rest of that platelet's lifespan, it's kind of useless. So aspirin is a great drug for platelet problems. Really doesn't do that much for example, if you have a clotting factor problem, doesn't really work on the factors. Finally, primary myelofibrosis is a myeloproliferative disorder, which again is going to be just a stem cell neoplasia inside the bone marrow, in which a particular cell type is dividing, growing out of control. And in the case of myelofibrosis, you might look at this and say, oh, it's the bone marrow fibroblasts that are dividing out of control, but that's wrong. This is technically a megakaryocyte cancer. So please understand, megakaryocytes make these two cytokines, platelet-derived growth factor and transforming growth factor beta, and those two growth factors activate fibroblasts to get them to throw down some type 3 collagen, which is called reticulin, which you can see with some specific stains. And understand that over time, this type 3 collagen likes to slowly progress to dense, diffuse type 1 collagen. It'll transform itself as it cross-links more and more tightly. So here it is in the SDL saying that the fibrosis is due to PDGF and TGF-beta synthesized by megakaryocytes, and that this fibrosis over time leads to cytopenias as the bone marrow is eradicated. So this is the one myeloproliferative disorder presenting with big bad cytopenias. Now it's called primary myelofibrosis because you can actually see bone marrow fibrosis in a few other disorders. Polycythemia vera can lead to a myelofibrosis, and so can essential thrombocythemia. But we would not call those primary myelofibroses. We would call them secondary to PV or ET. And so you're looking at presence of cells in the blood. If you get a high red blood cell count, then you get this myelofibrosis. It's going to be secondary to polycythemia. Same thing with ET. High platelets and then the fibrosis, okay, it's secondary to ET. But if you don't have a cytosis and then all of a sudden all your cell lineages fall off a cliff, you know you've got a primary myelofibrosis. So it takes a long time to develop. You see marrow failure. As the marrow fails, you have to make blood cells somewhere, so your liver and spleen and lymph nodes will swell. These dacryocytes, dacros means tear. I think it's ancient Greek. And These red blood cells called dacryocytes are shaped like a teardrop because any red blood cell that is still in the marrow, any stem cell that becomes a red blood cell in the marrow, to get out of the marrow, you kind of got to take a machete and go through all that fibrosis that's a result of this disease process. And so in the process of, walking through that fibrotic jungle, the red blood cell gets a little bit hurt. And so when it gets hurt, it cries a little bit, just like you or I do when something gets really painful. And so because it's crying, it just adopts the shape of a teardrop. It says, I identify with my pain now. And so that red cell's made it to the marrow. It's got out of the made it to the bloodstream out of the fibrotic marrow, and it's shaped like a tear permanently. So that's a dacryocyte. Now, because the marrow's fibrosed, obviously you get a dry tap. Duh. And because the bone marrow is fibrosed, obviously, if you go look at it under a microscope, you see a huge degree of fibrosis. So this is a pretty easy diagnosis as well. The driver mutation is same thing as 3 of our other 4 myeloproliferatives. It's that JAK2 mutation. Understand. This is a megakaryocyte neoplasm. You see hyperplasia of morphologically abnormal megakaryocytes, and it's a clonal expansion of them. So we do have a kinase inhibitor against JAK2 kinase called ruxolitinib. And at the very end, primary causes of death from myelofibrosis include infection. Okay, you're not making white cells. Makes a lot of sense. Leukemic transformation, which could happen in a minority of cases. Heart failure from the anemia, I would suspect. Bleeding from a platelet dysfunction is, again, your bone marrow is getting wiped out. Pulmonary embolism, maybe if you go to the other side of that, and you've got abnormal megakaryocyte proliferation, I suppose you could see either phenotype. And then hepatic failure caused by swelling of the liver, extramedullary hematopoiesis. So that's that SDL. Let's look at a few more photos of these last 2 myeloproliferative disorders. Here's essential thrombocytosis, and you will see atypical megakaryocytes in the bone marrow biopsy with this ET pathology. They're going to be very, very multinucleated. Remember, the megakaryocyte is a cell that's kind of got some blurred boundaries to it. It's not got nice circumscribed cell membranes. They're kind of fuzzy. And so you'll just see way too many megakaryocytes in the marrow. And if you look at the peripheral smear, I think this is very important here on the right side of the screen. You see platelets all over the place in the peripheral smear. That's what lets you know you're dealing with an essential thrombocytosis. Here again is a pretty atypical megakaryocyte that is humongous. And it's got a hypersegmented nucleus that's also characteristic for ET. Here is primary myelofibrosis, in which you also see atypical megakaryocytes, which is why we brought up small megakaryocytes in CML earlier, just partly fascination, partly useful. So if you look at the bone marrow in myelofibrosis, it stains positive for anything that can stain collagen and reticulin, and those black fibers on the screen are the connective proteins. Here's actual bone down in the lower left of this image. And then again, every single little black striated line right there, that's collagen, extracellular collagen holding everything together. Type 3, and then eventually type 1. And recall that type 3 collagen is called reticulin. So notice where the reticulin is. It's around the outlines of cells. It's holding them together outside their cytoplasms. So more of the same exact thing. There's this Gomery silver stain we can use to see reticulin. There's a Mason's trichrome that we can use to see collagen, and that's got a typical red, white, and blue appearance. Notice that the bone marrow in the upper right quadrant of this left image is red, and that collagen tends to be blue on that Mason's trichrome. And that's about all that I have to look at this point. I hope that you understand myeloproliferative disorders. Again, we have 4 of them. You could have too many white cells, that would be a CML. You could have too many red cells, that would be a polycythemia vera. You could have too many platelets, that would be an essential thrombocytosis. And then you could have fibrosis of the bone marrow. That would also be a megakaryocyte disorder. Understand all of our myeloproliferative disorders are essentially cancers of a stem cell of the myeloid lineage. And so the cell that gets the cancer is going to grow out of control to the point where you start to see its products in the peripheral blood, which is why all myeloproliferative disorders, except for fibrosis, present with a cytosis of the affected cell line. And for CML, remember that it always has 922 BCR-ABL tyrosine kinase. It's constitutively active. It's a fusion protein, and we use imatinib for it. If you can remember that, you got just about every question on this upcoming test.